Woo! Live from Long Island, New York. Hi, it's Love, Death, and Taxes, and we have a special guest today. Hi, Agnes. How are you? My special co-host is always here, over there, over that side.
The other way. Yes, I'm wonderful. Thank you for asking. I'm great.
You're doing well. Yes, and partially thanks to the guest who is coming in today. Dr.
Without him, I don't know what I'll be doing. I'm telling you. Honest truth.
Excellent, excellent. All right, so ladies and gents, if you are seeing this for the very first time because you are on LinkedIn, today is the first day we are broadcasting to LinkedIn, Agnes. So we are expanding into other places, right? And I see already there are a bunch of people who are looking in. But I just want to introduce you guys to this show. This is Love, Death, and Taxes. It is conversations about the inevitable, and as a result, we are going to be talking today to our very special guest about something that is very relatable and related to that. It will be back in just a second. Live again from New York, it's Love, Death, and Taxes. Hi, Dr. Stephen Dini is joining us today, and I want to say hello. Agnes has been just talking about you all the time. It's like, it might be the greatest podiatrist ever. I'm about to dump my own podiatrist to come see you, and there's nothing wrong with my feet.
Oh, well, thank you very much, Agnes. It's very nice. Actually, Agnes, if you don't mind me saying so.
It really is. You have to understand when I tell that. Yeah, but when I'm telling people that I had feet surgery on both of my feet, they think I'll be laying down for months, that I'm not going to be able to walk. Meanwhile, after the first one, the doctor Dini told me stay off my feet for 2 weeks. I was back to work after a week. And the second one, I stayed home for a week, but I was on my feet next day, same day, and no pain. How is that possible? You have magical hands. That's all what I can say. You have magic in your hands.
Okay, so
wonderful.
Dr. G, tell us a little about yourself. First of all, how did you get into? Why did you want to become a doctor? But then also, how did you get into podiatry specifically?
Okay, well, first off, let me just go off of what Agnes just said. Agnes, you are a wonderful patient. You followed all the instructions, and your post-op course went very easily because you listened and did exactly what I said. And this is why you're here now, and you had a great, post-op course. Other people, they take things into their own hands and maybe take my instructions very loosely, and they're going to be, more or less stuck in that post-op course where they're off the foot a little bit longer. So anyway, Agnes, you're a fantastic patient. She didn't call me at all. I was like, hello, I haven't heard from you. In fact, I always call all my patients the day after surgery. Yeah. Agnes, of course, doesn't pick up the phone after the first case. And I'm like, are you busy? What are you doing? So, but no, she was a great patient. And no, I really appreciate it. The doctor-patient relationship we have is actually wonderful. But to talk about how did I get started in this field? So, I never was like, in third grade talking to my elementary school teacher, like, yeah, I love feet and this is what I want to do the rest of my life. It kind of just came to me by process of elimination over time. So went to college, of course. I was a bio major. I went to Binghamton University, and I was lucky enough to have a lot of my friends also in the same major. We all were studying for biology late at night, chemistry, whatever the test was, and then came to the point where we were seniors and we're basically all trying to figure out what to do. So basically most of us, we were bio, so we're also pre-med. So we were applying to medical school, dental school. No one in my group of friends were applying to podiatry school, but my next door neighbor was a podiatrist, so I knew this my whole life. I happened to speak with him on it, and I thought his lifestyle was pretty great. And, he was just telling me the benefits of being a podiatrist. You could do surgery. You could be in the office all day. You could work in the hospital. There's really unlimited potential with the field. So I kind of eliminated down to dental school and podiatry school. And I have a unbelievable fear of a dentist since I was a child. It's gotten better now. I'm pretty good now. In fact, I just went to the dentist yesterday. I think I give myself a B- for that visit. I was okay. But I said, all right, why am I even applying to dental school if I can't even go to the dentist? So I went with podiatry school, and well, here I am now. So it all worked out. You know, it ended up being, I ended up loving the field. So that's how it went.
You're wonderful.
I can't imagine. I can't imagine what the conversation would go like if you said to your third grade teacher, you know, I really love feet. Like that would be completely
straight to the principal's office, you know, put me on the put me on the list of people to watch.
Can you imagine? She's sitting behind her desk constantly just
There's something weird about that one.
Dr. Stephen. Oh, that would be crazy. But yeah, literally, you are coming from a surgery that you did today, yes?
This is correct. Yes, very much delayed surgery, of course. So,
yeah, well, exactly. We were supposed to start this at a different time, and we had to, bounce around, which also is a part of the whole being a doctor and or being on call at how many hospitals here in Long Island?
So in the past 2 weeks, I've been on call at 3 different hospitals. So this was, so I was at LIJ, Long Island Jewish, North Shore University Hospital, as well as Huntington Hospital. So, I was trying to basically have a couple of cases today that needed to go. And when you work at a hospital, anytime you do surgery at the hospital, you have to go into it saying, I might not be leaving here while the sun's still up. There's always that possibility because you're going to get delayed. You don't know what's going to happen. And it's just like being on call. You're kind of used to it. Like when you're on call at a hospital, you never know what's going to happen. You might have to drop everything that you're doing on the fly and race over there, and you can't predict this. And the same thing goes for planned procedures. When you're doing a planned surgery, not an emergency, one that you say, all right, I want to do my case at 11 o'clock. It never goes on time. So, they kind of steal your time away, unfortunately, and you never know what's going to happen. So, but it ended up working out well. I came here.
Mm-hmm. You went on time with both of my surgeries, so I can't complain.
Well, that's different. This is the benefit. We were at an ambulatory center. So an ambulatory surgery center is usually it's not usually associated with a hospital. There are no emergencies that can go in there and basically say, all right, we're kicking you out. So, this is the scenario. Yours was the first case of the day at an ambulatory center. If I was delayed, I would have been shocked.
Yeah. Well, I ask you today to come and like we do Love, Death, and Taxes. This episode falls under love, self-care. And as women love to work, they like to look nice and walk on high heels. And I brought an example of a shoe that I will never wear again. What would you say
let's
about
say,
women?
Oh my goodness.
Those kind of shoes.
A weapon. Looks like a weapon.
Yes, absolutely, it is. It's yes.
Yeah, you can bludgeon someone with one part and stab them with the other part. You're totally right. It could technically be a weapon.
Yes.
But
yes.
most women, those are very common. That's a very common style of shoe that women wear. Is that like, I like to go into a personal story. I know sometimes you touch the bottom of some women's and right underwear, that the ball of their feet, it's very hard because of shoes like that. Doc, what can they do to not have that happen?
All right. Well, let's, if you have that shoe still available, maybe can we look at it on the screen? I want you to show me basically the view of it, how if you look top down, so where you can see your toes, if you can show that. All right, perfect.
Right here.
Perfect. Now,
yes.
Is there anyone on the face of the planet that toes end up naturally end up just pointing that way.
No.
No, right?
Of course
But
not.
if you wear a shoe like this over time, it's going to create that for you. It's going to make that happen.
Yeah.
Now we know this, right?
Yeah.
This is when you have bunion deformities form, hammer toe deformities, and this is only because you're wearing a shoe that's basically it's a vice for the most part, and it's pushing everything together. So over time, you get these deformities, and they can be very painful. So, this is what I see in my office quite often. Now, there's some people who come into my office where they have a bunion, they wear high-heeled shoes their whole entire life, and they're like, you know what, doc, it doesn't bother me, but I still want to correct it. I want to have a normal foot. I say, you know what, you're lucky if it's not painful, leave it alone. We'll watch over it, and if over time it does become bothersome, we'll take care of it. Others, they have this pain that develops, the bunion deformity. I wish I had a picture or something to show the audience from home, but this is something that has to lead to surgery at one point. If you want to be out of pain, or you switch to conservative shoes like sneakers, like New Balance sneakers. And a lot of people say, no, I'm never going to wear those types of shoes. So this is like a debate in my office I have quite often,
Really? See, I worked in Manhattan, I'm back and forth. And so I know that most women who work in offices in Manhattan may have 2, 3, 4, 5 pairs of shoes under their desk, but also on their way to work, they would wear almost orthopedic nurse looking shoes on the way to work. Is that no longer a thing? I thought that.
No, that is actually what if let's say someone is working on Wall Street, working in a law practice, or they're in court. I actually have quite a few patients that are lawyers and they're like, I am not wearing anything but high-heeled shoes, professional shoes while at work. So I say a couple of things. Number one, it's not easy being a woman. We know this. It really is not. And the other saying I say constantly is fashion kills. These two things, and we can get into pedicures and all that. I'll just stick with the bunion, the forefoot deformities for now. But pedicures is a whole other conversation. But women feel the need to try to look the part. I wear sneakers and scrubs to work every day. I have no issues. This is not a problem in my life. But women have this issue, and it makes them feel confident. It makes them feel good. And if I said, listen, you got these problems, you got to wear wide New Balance sneakers to work, they're going to be like, that I'm not doing that. That's crazy. So we have to fine tune to everyone's needs. In fact, a lot of the things I have to do is be a detective when I'm a doctor. Someone comes to the office, I have to gauge a lot of different things. All right, you might have a bunion. It might look exactly like the bunion from the last patient before, but the social issues that arise around the patient, the occupation, all this can take into part. So if I had a woman who's in their 30s and has 4 children and is working from home or is just watching the kids, and I say, could you wear New Balance sneakers? Stop wearing high-heeled shoes. I think that's an easier conversation to have than the woman who's in a professional environment every day, let's say in court, and they're going up against another woman who's wearing high-heeled shoes. And if she was wearing, more of an athletic shoe gear, well, it may affect her performance, or she might be consciously thinking that,
Right.
at work and become self-conscious. So we try to find a place in between, right? I say, all right, if you have to wear something in court, have your sneakers on the way to work, right before you go into the courtroom. Put them in some type of bag or whatever you have, and try to limit the amount of time that you're actually using these shoes, which in the end cause such severe issues.
So
I have
there's
another issue to show you.
Go ahead.
I have
You have
another
another
issue to show you. Yeah, there are professional dancing shoes. They're a little bit wider.
Well, they're a little better. Yeah, they're getting better.
Yeah. So will they be in lower heel? And there is a big protection here. So are they're okay for a couple hours a week?
When I give my recommendation, I guess a couple hours would be fine. I usually say 1 inch heels or wedges would be the best option. But I don't like none of these shoes are good. None of them are great. But if you have to a couple hours for dancing or whatever, you're going out to dinner, I think I could say, all right, that's fine. On a daily basis, right when you wake up or after the showers, you're going to get changed and you're in it for hours at a time each day. That's when I would probably say, all right, you're probably pushing it. But those are better than the first. I will say that.
Is there something you could do to adjust them? Like, just, the Dr. Scholl's has all these different things that you see sometimes when you go into the pharmacy, like all these different pads and whatever. And then maybe even something that you could put at the bottom of the shoe so that you're not constantly like hammering into the bottom of your foot and hurting yourself.
Well, have you ever heard a woman walk with high-heeled shoes down a block? Or remember in elementary school or junior high school, you can hear them down the hallway, and it's like a click, clock, click, clock, click. Those are, you're like hammering your foot. There's not really much you can do to really prevent that from occurring, that hammering onto the foot. If you had a callus, and I'm sure, Agnes, you probably had a callus or a blister from high-heeled shoes before. There's padding you can put on there to kind of soothe the area. But if you could just continue to wear that shoe, it's going to continue to happen. So the two things I want you to consider when you're looking at these shoes, or, women, when they're buying shoes, no one ever looks at the anatomy of the shoe. They say, this is cute. This is a nice color. And I'll be honest with you, even when it came to shoes that I bought, now, I'm not buying high-heeled shoes, but the shoes that I bought, let's think like, running shoes, of Jordans. I was a big Jordan guy for a while, but I never looked at the shoe. So let's say you went from one pair of shoes that was New Balance, and I had a heel in the back, and the heel in the back, let's just say 2 centimeters off the ground. And then you switch to another shoe where the heel, let's say, was 1 centimeter off the ground, right? That's going to change the whole biomechanics of how you walk, that drop in the heel. And high-heeled shoes, let's look at this. You're raising your heel. When you do that, you're shortening your Achilles tendon. The longer you do that, the more your Achilles tendon will stay in that position. It would stay shorter for a longer period of time. So then let's say you start waking up in the morning and start feeling pain. It's because now your foot's right on the floor and it can't hit that floor anymore. It's so used to being up in the air from your shoes. So I always have people look at
constantly pointed feet, right? That I've seen that, like on a woman's,
yes,
it's constantly pointed. It's like she can't get out of that position. And I understand what you're doing. Two things. One, yes, you want to get a little bit higher or a little bit taller, right? But then also, I think what they're trying to get is that sexy calf, like in the back is pushed up. That's what they're looking for. Isn't that also a problem that you see a lot? Like feet are one thing, but also are you dealing with this issue of their leg, their entire leg almost being like in spasms at some point because it's stuck in that position?
Oh yeah, well, it goes right back to that shortened Achilles. So that's basically saying that your Achilles is too short. So this is another thing you see is that, sometimes people who wear high-heeled shoes, they switch from those pretty high-heeled shoes to their pretty sandals in the summertime comes around. Sandals are much lower to the ground. And then people say, why am I having this severe pain in the back of my heel? And that is because you have a very tight Achilles tendon secondary to utilizing these shoes for so long. These are the patients I say, if you want to feel better, you have to wake up in the morning and start doing stretching, right? You have to stretch every single day to get out of it. It took years to probably get to this point. It's going to take time to get out of it. So I see this a lot, and you see plantar fasciitis associated with the Achilles tendon and the plantar fascia flow into each other. So they're a unit. So if you have a tight Achilles tendon, you have a tight plantar fascia. So you're going to have to address that with long-term stretching. And obviously, if it gets severe, we move on to cortisone injections, anti-inflammatories, physical therapy, and things get a little bit more involved. But the longer you use these shoes, the more of a risk you're going to have that. And then when we go to the front of the foot, the toe box, this is where the big deformities occur that you see, all over the place, the bunions and hammer toes. Crunching your foot together, it's like almost like a vice. Yeah. When you put it together on that shoe, when you stick it all in there, over time, your foot will end up developing the shape of that shoe. All right, and it's not for a good thing.
No question. And by the way, Doc, I realized this many, many years ago, like in my 20s. One of my feet is almost half a size bigger than the other. The left foot is literally bigger than the other foot. And so I always, if I go and buy a shoe and I put it on the right foot, I know it's fit on the left one. And then I'm going to have issues. And all it is crowding. It's like trying to push your feet. It's almost like binding. Like I'm sure you've seen like the old Japanese thing where people like used to bind feet to make them small. That's how if I put them in the wrong foot. So I don't know. I mean, that's the thing. What do you do? Can you buy? No shoe store is going to let me buy a shoe the half size and the other side.
No.
Custom made.
So
Custom made.
I hear that all the time. I hear that some people just buy two different sizes and they take the right and the left from each box that's going to fit them. Sometimes you don't have an answer. The simplest answer is usually the answer, but also this is probably the more the financially costly answer. But at the same time, I always say getting a wider pair of shoes, like if you say a wider pair of sneakers or whatever to accommodate for that may help, but it depends on you. Depends on what you feel comfortable with. So, and also depends on what brand you buy. Every brand's different,
That's the other thing. I can only wear, oh my gosh, I'm going to shout them out on here. I can only wear Adidas. I cannot wear Nike. Arch in the bottom pushes up into the bottom of my thing. Oh, you hate Adidas?
Listen.
I don't think so.
I have one more quick question because there is extremely popular nowadays, especially on TV. You see those procedures. Oh, if you have a bunion, we can do this procedure, and in 6 months' time, you're going to be back on your feet. Is it really 6 months?
6 months? No, sooner than that. So, all right, I'll dive into this. Bunion surgeries, there are literally hundreds of different types over the years, since when surgery started, and we even find as podiatrists, even orthopedic surgeons, we've been tweaking this over time, and I have to say, within the past couple of years, a lot of great things have come from bunion surgeries. Before, let's just say, back when I started, it wasn't necessary. You're going to get good results. It's hard to get perfection. I should never even use the word perfection, but it's hard to get near perfect results. Okay. And you always had very individualistic results. Each person had a different bunion. Each result was different. And now there's been new techniques and new instrumentation that has come out. I'll tell you one of them I happen to like quite a bit is the Lapiplasty procedure, and very interesting company. They're doing great marketing, and they're actually, instead of targeting the doctors to use their instrumentation, they're targeting the patients. So for a while there, they were seeing their ads on Instagram. They talked about their bunions to their friends, and like, my bunion's killing me, and then they have an Instagram ad showing this procedure. So this is very nuanced.
Sorry. That's me and my people doing that. I'm sorry.
But it was odd. I was working in the city at the time when this kind of marketing started. So people would just come into my office and I want a Lapiplasty procedure. And I'm like, no. I'm like, I don't think you can decide what procedure you want. And so eventually more and more people were doing it. And then I started getting some discussion with other doctors, and they're saying, this actually is a great, great product. The patients are asking for it, but at the same time, though, the company's coming through with results. So I ended up doing the training for it, and it is amazing. It is incredible. So it allows you to weight bear a lot sooner. So the company says the first couple of days, I'm a little bit more conservative. I put people into a splint to kind of control all the swelling for the first week or so. But after a week or 2 weeks, I put people into a boot and they can walk on it. This is a take on a prior procedure, an old procedure, which I did many, many times. That procedure, I used to keep them in a splint or non-weight bearing for 6 to 8 weeks. So this is a big change. So to be able to walk, be able to walk, possibly go back to work within a week to 2 weeks is enormous. So before, when I told people you have this deformity, this is the surgery you want to do, I put a plate and screws inside your foot to hold the reduction. You're going to be off your foot for 6 to 8 weeks. And if it's your driving foot, it could be, a while before you drive. Everyone's like, thanks a lot, doc, but no thanks. I don't think I want to go this way, even though I know it's the right procedure for me to prevent a relapse.
And no trips to Poland in that either. Sorry, you're gonna get.
I'm sorry.
No trips to Poland to on the flight.
No, absolutely not.
Yeah,
absolutely not.
What are you carrying in your foot, sir?
So this is where we're at. So big changes happened recently, and it's due to the hardware, the technology, the engineering of the hardware itself. It allows you to weight bear a lot sooner. It's pretty incredible. And we also have another take on an old technique. Is called the MIS, or minimally invasive surgery technique to treat bunions. So Agnes, can we discuss
absolutely
your surgery a little? All right. So Agnes had for one of her foot, one foot she had a open procedure where you make an incision to the foot and go down to the bone. She had a more of an arthritic change as opposed to the classical bunion where the toe gets dislocated. So this kind of needs a cleanup of the joint. So one foot was worse than the other. So the other one we had to open up, which is a little more invasive. And the next foot, I said, all right, we can probably get away with the MIS technique. Again, that's minimally invasive surgery. This surgery, you make an incision, maybe about 0.5 centimeter in size, 2 stitches.
Wow.
So this is much less invasive. So the way I did this was more or less a bone or a joint cleanup. There was no breaking of the bone of shifting it over or use of screws. But I mean, Agnes can probably tell you the different, because she had both surgeries, an open versus a minimally invasive. So, you don't usually see something like that, but you have the ability to compare. So MIS has a place in the field of podiatry. It is great for dealing with some patients who, let's just say, have a mild to moderate deformity, or if someone has, let's just say, diabetes, or very poor circulation to their feet. You don't have to worry about making this enormous incision. You can make a small incision, and you don't have to do too much, I don't want to say destruction, but too much damage to the tissues around it. Obviously, as soon as you make an incision on a foot or anywhere in the skin, there is always a risk of increased swelling, possibly touching a nerve, affecting the tendons. All this is a possibility. So MIS significantly reduces that. But that's where we're at right now. There's basically a huge dichotomy right now with surgeons learning this MIS technique, learning Lapiplasty, or doing both of them. So I'm doing a little bit of both.
And you're wonderful at what you're doing, and the way I feel is wonderful. My husband was scared after the surgeries how much he's going to have to do for me, and he was pleasantly surprised that I was on my feet same day. I mean, I walked out from there, got into the car, walked into the house. Yes, I did take it easy as much as my crazy mind allowed me, because I cannot sit still. I have a problem with that. But I feel wonderful. I really feel wonderful. And I have to tell you that the swelling on the last foot that you operated on, it's less than on the other one, that the first one that you did, the full incision and everything else. So it's just wonderful. I cannot express how grateful I am that I met you, that you are my surgeon, and whoever has any problem with their feet, please see Dr. Dini. He's a magician. That's all what I have to say.
All right, well, I appreciate that. Thank you so much.
That one was minimally invasive, Doc. The surgery that you did today, you mentioned to me that it might be removing someone's foot, or is it like their whole foot,
yes,
or part of the foot? Like that is probably a different kind of surgery, and that's going to the death portion of the show, Agnes.
Yes. So if you want to, so we were talking about shoes, and we talked about how women have it hard, and the fashion that you have to wear could possibly lead to surgery one day or chronic pain and all this stuff. But so I have a very versatile job. So I'm in the office, right? When I'm in the office, you see anywhere from elderly patients coming in for just routine care, and there's a lot of stuff going on with elderly feet. We know this, to people who break their bones or who might need some type of surgery to correct a fracture or reduce a fracture, versus small things like hammer toes, bunions, neuromas. But then we have the hospital, and the hospital is a different animal. That's where we see infections that at times, unfortunately, could be life-threatening or limb-threatening, meaning that if we don't do something soon, within a day or within a couple of hours, this patient could possibly lose their leg. That's how serious these infections are. The foot's the farthest spot from your heart, all right? So the vessels get very, very small, all right? So healing in your foot is a lot harder to heal something in your foot than on your chest or on your arm. And a lot of people, and I know you're going to know exactly what I'm going to say next. A lot of these patients I see are also diabetics, right? And diabetes it's one of those problems that it's a silent killer. It really is, because most people feel fine. They'll go to their endocrinologist or medical doctor and say, all right, your A1C is elevated. And they go, oh, well, I feel okay. But then you get a small little cut on your foot, or, something little happens, or you cut your nail. You try to cut your nail yourself. You try to cut out an ingrown nail. And this little cut doesn't heal for a week, doesn't look so bad, maybe 2 weeks. And the problem with diabetes is that it affects the nerves. It affects circulation and the nerves. So you might not feel it. But for someone like you or I, it might be really painful. We're like, I need to go see a doctor. But for them, it's delayed. It's a delayed effect. So anyway, this is what we see at the hospital. We see these infections that probably have been brewing for a while. Sometimes they lead to gangrene, which is basically a complete loss of the soft tissue envelope, or even the bone actually just dies and it turns black. I'm sure you might have seen pictures of this, but the hospital is a different animal. So I'm doing a little bit of everything. I'm at the office, I'm in the hospital doing these patients, and the conversations you have with patients in the hospital saying, I'm going to have to amputate your foot, and you're just meeting them within, that day, and you're making this huge decision for them going forward. It's a big change from in the office when you're talking about you can't wear high-heeled shoes while you walk to work anymore, so you have to have that versatility in how you practice and how you talk to patients too.
It's partially the reason why they're seeing you for the first time, because they have not gone to the doctor in quite some time. And that's why it's gotten to this point, though. I mean, what are the signs that you should be looking for? You're looking at your foot, and the next thing you know, it has to happen over a period of time. Something is not healing, or something doesn't have a right color, or what signs are we looking for to stop that from happening?
Well, I think if you want to have real good preventative medicine, if you get diagnosed with diabetes, next step is to make an appointment with a podiatrist. All right. You also see an eye surgeon or an eye doctor as well, because diabetes can affect the eye. So if you want to be absolutely cautious, you're at a doctor's office saying, hey, you might be a pre-diabetic based on your labs. And that should be your next step, because it is going to be a change in your lifestyle going forward. You should be dieting, exercising, and little things like small cuts. A lot of people have ingrown nails that don't even know it. And if you use one of those classic flathead nail cutters you get at CVS, you can have a risk of cutting your skin and leading to a lot of issues. And we see this at the hospital all the time. We see these patients coming in saying the same thing. I cut my nail a couple of days ago, or I stepped on something a couple of days ago. This is kind of the start. Now, when it comes to infection, or if it comes to let's say you're a diabetic already, or you're older, or you have a history of PVD, peripheral vascular disease, or you're a smoker. I know it sounds silly, but small cuts on the foot is how it starts usually. And no one's going to run to the doctor right away, but you really should. And sometimes I have people come in, I tell them, like, come in if anything comes in, anything pops up on your foot, you come in and show me. And sometimes it's a quick conversation. I'm like, here's a Band-Aid, topical antibiotic. It's fine, but do this. Don't walk barefoot, right? Wear this type of shoe when you're going out, or kind of like small little pieces of advice, but it sounds small, but it prevents a significant amount of these issues in the end.
It's a big deal.
It is a big deal.
I keep seeing these. I can't really call them ads. They're more public service announcements. And there's this like a woman saying, "I couldn't believe it when the doctor told me I had to remove all 3 of these toes just because I was smoking. My advice: stop smoking before you lose your toes." And I was like, "What? I had no idea that smoking could."
Well, don't start smoking. I think that should be the number one thing.
But yeah, it's fascinating. But Doc, I know you're a busy guy. I know you've got other things to do today. I am so grateful. We are so grateful that you can come and hang out with us and chat to us and talk to us. Where, if someone did have some problem, where would they come to find Dr.
I didn't. I forgot to tell you where I'm at. I'm trying to like keep myself hidden. So I work for Optum. Optum is a very, very large company. It's across the nation, but they recently took over what Long Islanders probably remember as Pro Health. And I have an office in Smithtown, which is off of Hop Hog Road, 50 Hop Hog Road. And I have another office in Garden City Park. All right. The hospitals I work at, I mentioned it earlier: North Shore University Hospital, Long Island Jewish, and Huntington Hospital. But those offices you can find me at. You can Google my name, and all my information would pop up. Listen, give me a call. We can come check you out in the office anytime.
Very well, ladies and gentlemen, I'll put all that information into the comments and the commentary in the bottom of these the videos. This is going to be on, well, it is already on YouTube. It's on Facebook. And today, welcome LinkedIn viewers. It's now on LinkedIn. Yes. So thank you so very much, Doctor. Ladies and gents, I think that's going to be it for us for today for Love, Death, and Taxes. Agnes, do you have anything final that you'd like to say, either to Dr. Dini or
I keep telling you for the last couple of episodes that Dr. Dini, finally you met him, he is wonderful. All the advices you gave me, I have to tell you, it's working. The exercises, like you said, it really elevates a lot of different issues that I had, and yes, and your instructions, and they are not that difficult to follow. But I also have to tell you, I met a lot of doctors in my life. You are very easy to talk to. You are very understanding. Your relationship with your patients it's very easy, which I can really appreciate, because a lot of doctors are, well, statistically, I don't want to be a statistic when I'm coming to see a doctor about me, about my problem. So you are wonderful. You're not only gifted surgeon, which I can attest to because I can dance again, and literally, and you are easy to communicate with, and you are very accessible to patients. So anyone who's got problems, please go see Dr. Dini either at Smithtown or Garden City offices. And the girl who is at your office, she is so sweet. She's so wonderful and understanding. You guys are just wonderful. I have
thank you. Her name is B, and I'm very thankful to have her too. Very, very much. She's excellent. She's amazing for our office.
Yes. Set the tone, and it just follows. And whoever you're working with normally does that. The conversation that I had with him yesterday or the day before, when we were leading up to this, and I wanted, he's checking us out to make sure that we weren't going to, expose his patients or anything, Doc. He said to me, you kind of have to think of, and whenever I hear this from a doctor, this is the doctor that I would like to go to. He says, you kind of have to think about your patients as your family. What would you do for them? How are you going to treat them? Because they are looking for you to reassure them, and also they're hoping that you are going to do the thing that's in their best possible interest. And I love that. I absolutely love that. Thank you so very much, Doc.
Thank you.
I really appreciate it, guys. Thank you. Really appreciate it.
Thank you.
Problem.
Have a great day.
That'll be it. Thank you so very much. Ladies and gentlemen, thank you so very much for hanging out with us at Love, Death, and Taxes. If you want to send us some information, you want to suggest a guest, you want to suggest some questions, or you have questions for our current guest, send it to mailbag@lovedeathandtaxes.com. And if you are looking for tax resolution services, you want to go to nytaxresolutions.com. That's where you're going to find Agnes, and Agnes will take care of all your stuff, right? And I'm Orion O'Neill Williams. And on behalf of our guest and Agnes today, I'd like to say thank you guys for hanging out with us today. All right, take care. Have a good day.
Bye-bye.